Greetings and welcome to the Deep Dive. This is the place where we take really specialized medical topics and, well, we give you the essential roadmap to understanding them. We know you're here to get a crystal clear picture of this fascinating area where, anatomy meets mechanics. So we're jumping right in. And for this deep dive, our source material is built entirely around excerpts from Dr. G.S. Raju's YouTube channel. Specifically, we're looking at the video HEC 1472 Lesson 13A, Stricture, Dilation, Strictures, and Dilators. We're really dissecting the clinical decisions here.
That's right. Our mission today is pretty concise. We are unpacking the connection between the physical shape of an esophageal injury and the specific tool you need to fix it. We have to define the two major stricture types, that's simple versus complex, because that classification is really the single most important decision point. Then we'll get into the tools themselves, the dilators, bougies and balloons. They work in radically different ways.
Okay, so let's start with the problem itself. It begins, like so many issues in the gut, with inflammation. If you think about the lower end of the esophagus, if there's severe persistent inflammation there, what we call esophagitis, it's more than just discomfort, right?
Oh, absolutely. If that inflammation goes deep enough into the wall of the esophagus, the body, it tries to repair the damage. And that repair process, it involves scarring. And scar tissue, well, by its very nature, it's just not as elastic as healthy tissue. When it contracts, it causes a narrowing, a constriction. And that is exactly what we call a stricture.
So the tube narrows, and its whole function-moving food down to the stomach is suddenly compromised.
Precisely. And the patient immediately feels it. They experience dysphagia, which is the technical term for difficulty swallowing. Food just gets stuck.
So the goal is to help the patient by stretching that esophagus back open. The process is called dilation.
It is, but as the source material makes so clear, the how you do it depends entirely on the what. What kind of stricture are you looking at?
Right. And this is where we have to categorize the anatomy of the block. As a clinician, your first step is figuring out which of the two camps this stricture falls into.
That's the critical distinction. It's really a risk assessment, more than anything. We're looking at simple strictures versus complex strictures.
Okay, so let's start with simple.
Simple strictures are, kind of our best case scenarios. They're short. The opening is generally not too tight. We call this wide bore.
Wide bore, okay.
And often the endoscopist can actually see clearly right through the narrow segment all the way into the stomach below.
The source material gives a couple of great examples. If a patient says meat or apples or bread always gets stuck, is that an immediate flag for a Schatzki's ring?
That is the classic presentation, yes. A Schatzki's ring is just a thin ring of tissue very close to the G-junction where the esophagus meets the stomach. Because it's short, it's straight, it's not angulated, it's considered simple. A mucosal web would be another example.
So it's almost like a mechanical bottleneck, like a little shelf inside a pipe. Why is that physical trait, short and straight, so important for the procedure?
Because it relates directly to safety and technique. Since the passage is short and you can see it well, the risk of misdirecting your tool is low. Simple strictures can often be dilated with just a basic bougie dilator, and sometimes you don't even need a guide wire to safely direct it.
So non-wire guided.
Exactly. The realm of non-wire guided bougie dilation.
Okay, that makes sense. Low risk, simple approach. Now, let's pivot to the really challenging cases. The complex strictures. This is where the stakes get a lot higher.
They really do. Complex strictures have characteristics that turn a simple dilation into a high-precision maneuver. They're defined by being very tight, significantly longer than simple ones, and sometimes they're angulated.
Angulated meaning crooked, not a straight path.
Precisely. A common example from the sources is a tight peptic stricture, which is caused by severe acid reflux damage over time.
And when you combine that tightness and length with a potential curve or a bend, the challenge must be just navigating that tunnel without causing a disaster.
That's it, exactly. If you try to push a dilator blindly down a long, tight, or crooked stricture, it's going to meet serious resistance. And if the instrument can't pass, it has nowhere to go but to buckle or sort of coil up above the stricture.
And that coiling sounds catastrophic.
It is. It significantly risks puncturing the wall of the esophagus, a complication we call a perforation.
So the complexity of the stricture itself creates this non-negotiable safety rule.
Yeah.
You have to know the path before you insert the main tool.
Absolutely, sir. For any complex stricture, the method has to be meticulous. You use a thin, flexible guide wire, and you have to steer it through the entire stricture first. You guarantee the path.
Okay, so now we have the problem defined. Simple means low guidance. Complex demands high-precision wire guidance. Let's look at the instruments. Bougie versus balloon. What's the fundamental difference in how they work?
That's the key thing to understand. A bougie dilator relies on, well, physical geometry. It's a series of long, tapered tubes of increasing diameter. The mechanism is a physical push. You're applying a longitudinal force to shear and stretch the tissue as this cone shape passes through.
And you mentioned there are two kinds of these.
Right, the non-wire guided ones for the simple cases, and then the wire guided bougies. For those complex, high-risk cases, the guide wire basically funnels the bougie directly through the opening. That's what prevents that dangerous buckling and coiling we just talked about.
Okay, so if the bougie is all about pushing and stretching, a longitudinal shear force, what about the balloon dilator? It sounds like it works on a completely different principle.
It does entirely. A balloon dilator works on the principle of hydrostatic pressure. You're placing a deflated catheter into the stricture, and once it's in position, you inflate it. You're applying radial force.
Radial force, so stretching it outwards, sideways, instead of pushing through it.
Exactly. Pushing versus controlled radial expansion, it's a huge difference.
And that must require a much more specialized system, right? I mean, compared to just sliding a plastic tube over a wire.
It really does. The setup for a balloon dilation is all about control and measurement. To apply that radial force safely, you need a specialized system. It involves a syringe, fluid, and often a pressure device, sometimes called a gun, that lets the clinician apply a very specific, measurable force to hit a target pressure.
So the balloon allows for this measurable, controlled radial force. The bougie relies on the geometry of the cone and a physical push. Why would you ever choose a bougie for a complex case over the balloon, which seems so much more controlled?
That's an excellent question. It really gets into clinical preference. A potential advantage of the bougie is tactile feedback. Because you're physically pushing, you can often feel changes in resistance along the stricture that can be helpful.
I see.
But the balloon's ability to apply that sustained, measurable radial force and to do it symmetrically, that's its key differentiator. It minimizes that longitudinal tearing force. In a lot of centers, the balloon is preferred for extremely tight or resistant strictures because that controlled pressure can often get the job done with less risk of, pushing right through the wall.
So that gives you this great mental framework for it all. The bougie is geometry and a longitudinal push. The balloon is hydraulics and measured radial pressure. But what's the one overarching rule that applies to both of them?
The rule is simple, and it's absolute. If the stricture is complex, tight, long, or angulated, you must use a guide wire. The guide wire is the indispensable safety mechanism for any high-risk dilation. It doesn't matter if you choose the hydrostatic power of the balloon or the physical sizing of the bougie.
So what does this all mean for you? The key takeaway here is that the second you know if a stricture is simple, like a Schatzki's ring, versus complex, like a peptic stricture, you immediately know the treatment strategy.
It dictates everything. It tells you whether you can use simpler, non-wire-guided tools or if you must use the high-precision, wire-guided systems. It's just a powerful demonstration of how specialized medical engineering has to adapt perfectly to the physical hazards of the human body to minimize risk.
The body of the stricture dictates the approach of the tool. It's a fundamental principle.
It really is. And we've defined the what and the why of the tools, but, as the source material hints, the next logical step is the how.
Exactly. Since dilation often involves the clinician applying physical force, whether it's the push of a bougie or the pressure of a balloon, it raises a big question for you to think about. Since the clinician is essentially judging the necessary force to stretch tissue without tearing it, what are the crucial procedural steps or safety considerations for learning how to actually use a bougie dilator in practice? Think about the forces, the patient's position, the monitoring you'd need. That's what's waiting for us in the next session of this deep dive.